Thanks for the thumbs up. So I want to just basically go through some things, some stuff you're probably very familiar with, and hopefully we'll bring out some of the things that maybe you're not too familiar with. So the Healthcare Care Act 2022 enabled the integrated care systems, ICSs, to exist. So they came into operation in July of this year. Now each ICS has an integrated care board, and the idea is that they would bring together health and social care to be able to work closer together and work out priorities for the NHS. So when the integrated care boards were legally established, the clinical commissioning groups, such as they were before, were abolished. So I just wanted to show you, this is the 5 ICSs that have been that have set up in London, that have been replacing the previous CCGs and their footprints therein. So this project that I'm working on at the moment, I wanted to share with you. It's been arranged by the London Dementia Clinical Network. And then what they're doing is they're developing a commissioning framework for post-diagnostic support for people living with dementia. So it's all about, after the person's received that diagnosis, what happens then. And they want to kind of remove the postcode lottery that people really have been affected by, sort of the standardized dementia pathway and across all of the 5 London ICSs. Then we're going to pilot a framework, and then we can share this nationally with all the integrated care boards. So that's really the plan of it. The whole project has been funded by the Office for Health and Improvement and Disparities. So they're funding this work. And we're collaborating with UCL Partners, which are part of the Academic Health and Science Network for North London. And there's 15 of them across the country. And so we're working through this. I'm realizing that I'm just throwing a whole load of jargon at you at the same time, lots of different names of organizations and groups. There won't be a test later on. I will share my slides. So hopefully that will make a bit more sense. So we're going to I just wanted to show you some of the challenges that we were facing at this time. There's many different inequalities. And obviously, when we're talking about inequalities, people will wonder, well, what exactly does that mean? And I think especially what we're looking at are neighborhood level deprivation. So the explanation of this could be, you could be quite wealthy, you could be quite rich, but if you live in a rundown area, then you will not be able to make as best use of your environment as others with lower levels of neighborhood deprivation. So for example, if you lived in a tall tower block, the lift's broken down, and the only green space near you is a small playground, and that's where the drug dealers hang out, then you're much less likely to go out for a walk, to go out and get the exercise that you might need. So lots of inner city problems have this issue with neighborhood level deprivation. And there's a really interesting +1 study that's been taking place about looking at neighborhood deprivation across Essex. It's well worth a read, and I've put the links in the speaker notes for the reports and things to give the information about these things we're looking through. So it's definitely worth having a look through it. We also see an issue with people whose first language is not English. They also suffer from inequalities, often struggling to understand materials when they're translated. Often materials get translated using Google Translate and some other automated tools, and this doesn't have a meaning-based approach, and so quite often it's quite difficult for people to understand things. And also because a number of words haven't been coined in other languages as much as some of the places, it makes it quite difficult to maybe understand the concept of what's really trying to come through. So for example, in some South Asian languages, the word dementia is translated literally as madness. And the problems that actually has is quite significant, because this has led to a situation that was reported quite recently in Manchester, where GPs were prescribing antipsychotics to manage what it actually was dementia, because of this language barrier and language issues. So language has a huge impact upon inequality. The variation of provisions also means that we see that some groups are kind of not able to get the same access as they can in different different places and get different support. We know that people generally tend to live between 5 and 10 years following a diagnosis, but the level of support in each different local authority differs quite dramatically. So when we're speaking to people, they're saying, well, some of us are feeling great, we're supported throughout our lifetime, a very small percentage, but actually a number of people are saying, I get given a diagnosis and then that's it. I kind of feel lost. I don't really know where to go or what I'm trying to do. So we're looking at some of the outcomes and saying, well, actually, when we consider about how people are being supported, we know that if we can support people better in the community, then we can reduce the costs onto the NHS, the costs of the acute and primary care. So that kind of makes smart business sense. But also, if people have fewer injuries, they live healthier lives, then that can lead to improved standards of dignity in care. People tend to live longer in their homes and where they want to live. You know, Age UK studies showed that only 6% of older people choose to live in retirement accommodation. So people want to live in their own homes. They want to try and live in a way that helps them to be independent. And so this is really shows that the more we invest in keeping people independent and healthier, then it's easier just generally for everyone. So the London Dementia Clinical Network identified several areas that they needed for improvement, and they were trying to address these challenges. Now, I think the first focus on diagnosis rates is something that's been on the agenda for quite some time. The Prime Minister's Challenge on Dementia 2020, that really had a focus on increasing dementia rates. But of course, when COVID hit, many memory clinics struggled to really see patients and to see how they were managing. And so guidance was produced to help support that. So when we look at these different areas of improvement, we've been trying to help and support these areas and over the past year or so. So we've produced a report about a review of diagnostic tools and how to implement them locally in services, especially with a focus to doing them in a remote sense. But also we found that there's actually been a glut of recommendation and guidance and support tools that people have had. So people are not, clinicians are maybe less likely to try a new tool than the one they've always previously been using, unless they have been trained in them. And so having some new e-learning packages and some new learning packages help people be able to expand their use of different diagnostic tools that can support people in different arrangements and different settings. The idea is that there's a more blended hybrid model that can support people in different situations. When it's best for the patient to have face-to-face, then that's still available. But also we know that there are benefits to people having remote consultations. A number of patients we spoke to said they much preferred being in their own home, having the assessment without having to drive and use public transport and be concerned about navigation to and from the hospital. So that's one of the tools that we looked at. But what about the other two areas that was needed for development, tackling inequalities and the access issues and prevention? Well, this is the project I'm currently working on, a service evaluation. And it involves a number of different stages. Firstly, we're mapping the dementia services within London. We've emailed a number of different services with our flyer. We've been phoning the services again, they're phoning them and trying to send them through and send the flyer through again. We really want to try and reach as many different people as possible. We've got the 10 most common languages in London and translated the leaflet into those using healthcare professionals rather than just an automated process. And we're using local radio stations, we've got surveys. So we're really trying to get as many people to come back to us as possible. Up until this morning, we'd done 53 interviews with people living with dementia and their family and carers, and this will carry on until mid-October. So you might be wondering, well, what's our findings so far? Obviously, these are all quite tentative results. These aren't something that we're necessarily going to be publishing at this stage and sharing, but we just wanted to let you know about what's happening and what people's feelings are right now. Hopefully, these will be things that will resonate with you. So some of the feedback we've had is that people have very positive views of the NHS as an institution. They're proud of the NHS. Some of the quotes we got back was, "I can't praise the NHS enough." And they really liked individual health professionals, so we got some quotes back. Someone said, "The community care team, they had their own team of nurses. I can't tell you how brilliant, absolutely brilliant they've been. They're the only people apart from the ambulance crew that would come out and see the person living with dementia when she was in trouble." Another person said, "So it was like complete utter chaos from the GP side, but as soon as I got social service involved and the community care team, they were like working with you, people working and people who actually gave a damn." People living with dementia are also very positive about the community groups and the community. This is a couple of quotes we got. "I did access one of the dementia support groups. You really don't have to struggle with this on your own, and that was so useful to know. It was just so really useful. The funeral director ran a session at the care centre, and it was a right laugh. We didn't expect that, but we got all our questions answered." Another person said, "I think one of the things that was quite helpful for me was that I talked with age concern. I mean, it made me bawl my eyes out to think about the people who knew they had it coming on, but you learn about how to cope with it and manage it as well." People seem to have a view of a more critical view of perhaps the NHS systems. They saw individuals, people trying to work and try and make the system work for them, but it just doesn't seem to be happening. And they compared the system with supporting people with dementia to other systems, such as, if you get cancer, there seems to be a lot more coordinated approach. Someone had this quote they provided us when we had the interviews. "No one seems to look at the drug interactions that are taking place. They're so short-staffed. They prescribed this new drug, and if they'd given it to the person living with dementia without reading the side effects and looking on it, she would have died. No one has had the courtesy to talk to me about it at all. So what happened was, when I read the side effects, and I read on the side of it that it should not be issued with someone with kidney disease, well, that's what the relative has. I phoned up the GP, and they said, 'Oh, thank God you called back. Please don't give it to her. That's you made the right choice contacting us.'" So there's an issue that they were concerned about short staffing, and this actually is we actually got quite a few people that reported to us the same situation. People also told us they felt that there was a lack of training and awareness about situations. This was one person's experience. They said, "When the health appointment was made, I said, my relative has got dementia. She will scream and shout, but she can't help it. Have you got a room where, we're away from one another, from other people?" And they said, "Yes." And then halfway through her examination, a doctor came in from another room, and he screamed the room down. "I can't put up with all this noise. Her screaming and shouting is, I can't keep up with her screaming and shouting anymore. I'm trying to conduct a clinic next door." I said, "Excuse me, I appreciate you're a consultant, but we asked for a room away from other people, and there's no need to be like this. It's not her fault. She can't help it. She wouldn't do this if she knows what she was doing, you know." Another person said, "I could tell you that probably 95 or 99% of the professionals that we've been asked to speak with don't seem to have had any experience of living with someone with dementia or helping to exhibit the behavior that dementia has that we have to deal with." Another person, I thought this was quite interesting, another person said, "In terms of qualifications of people who come, every care company will tell you that they've got someone with dementia and all their carers are dementia trained. But I just have to say to that, really, I don't see that in evidence." So we were really seeing how care workers really seem to be struggling to manage behaviours that come across with dementia. GP surgeries were probably the most criticised, and it would seem to be due to a lack of responsiveness to people. For example, we got the quote, "When she was in trouble, we couldn't get in contact with the GP, couldn't get in touch with them." Another person said, "Well, at the moment, I'm not very happy with my GP. We won't be talking about the GP very much. They just gave us some tablets and said, 'I'll be in touch with you at the end of February.' And that was the support we got." And then I think doctors could have given me help, but I was left out the loop. I'm just left with my frustration more than anything else. So I think that when we were looking at the feedback we were getting, people were again and again coming to this issue of uncertainty. They were feeling frustrated and uncertain about the way to manage things. They had everyday questions and everyday comments they wanted to see. For example, how do I manage my relative who doesn't want to wear their coat when it's pouring with rain outside? How do I deal with these situations without constantly phoning someone who's not going to be able to take my call anyway? Why am I left with so much uncertainty when I'm dealing with this situation? And why can I not know what is the best course of action? What's the way to do this? So it's interesting because we were asking people how aware they were of, for example, the NICE guidance. Now, the NICE guidance is available for professionals. It has the full version. It also has the public-facing version. And of course, it's not just for the NHS. It'll be the standards that the CQC base their reviews on, and their reviews for social care providers as well. And it does make us wonder, actually, how many professionals have actually read it, looked at it and read it and gone through it. I was in Camden Care Centre yesterday. I was doing a consultation, a focus group, and one carer said to me, she said, the NICE guidance is very well written, but no one's read it, which I was pleased that she was aware of it and she knew what it was. Now, in the NICE guidance, it says that people should be offered the opportunity to engage with research, but most of the people we knew were unfamiliar with Join Dementia Research, which is the organisation designed to help people to fulfil this brief. So that these connections, these conversations aren't taking place. And then we were asking people about what kind of interventions they were offered to help them and support them emotionally, such as START, the strategies for relatives. And no one we spoke to has ever heard of START. They're not aware of it. Now, the NICE guidance was published in 2018, so this really feels like a concern. Now, we might get a few more people that are a bit more aware, and hopefully these numbers will reduce. But so far, this is what we've seen, and it's a bit concerning. I would like to play with you. We were able to record one of the interviews that she's given us permission to be able to share that with us today. Can I get a thumbs up once it starts playing? See whether you can hear this.
Today was a hard day. My husband Derek passed away this morning. Once they took his body away, I was at home alone for the first time in a long time. I kept thinking, what am I going to do now? How will I carry on? I'm 72. My life has revolved around caring him for the past 6 years. I remembered I told that I would come to this focus group, and I felt I had to come. I owed it to my late husband to tell his story. I started to get worried about him when he first started getting lost on his way back from the shops, but our GP thought he was just depressed. He didn't look into it. He said there was no treatment for it anyway. But I kept going back. Eventually, he did send us to the memory clinic for assessment. But then we were left a bit on our own. He was diagnosed with dementia, and it's like, oh well, that's it. Even just a quick checkup every year would have been good. And then we could see whether anything had changed. And it did change. When I started to struggle a little with the caring side of things, I reached out to social services for support. They told me the mental health team would take care of it, but when I contacted the mental health team, they told me it's a social issue and the social worker would need to deal with it. 6 weeks later, we'd still got no support, and a lot can happen in that time. It's kept on happening every time we asked for extra help, even right towards the end. Every year we get our appointment for our diabetic eye check. Why can't it be the same with dementia? Eventually we did get a package of care set up. I thought a nurse would be coming, but it was a home care worker, and I was shocked to find out how little training they receive. And then to make things worse, we always seem to have a different person. That's another thing. They're good carers and they're bad carers. And you've got to have proper specialist carers who know about dementia. Being married to someone living with dementia, it was like living with a stranger. Derek couldn't dress himself or shower. He couldn't understand that he couldn't work anymore. It was really hard. I came here today on the day my husband died because I want to see change. I had to come. If I don't help people who are trying to make things better, then I'd be part of the problem, not the solution. I don't want that to happen.
So that was basically an hour's interview, and we just sort of cut it down for a couple of minutes for today's session. We changed her name. Her name's not Shona, but we changed her name to protect her identity. And obviously, it's not the best recording in the world, but I thought it would be useful to share with you today. So this is the timeline of what we're going to be doing. For the rest of the rest of October, we're doing this service evaluation. And then in November, December, we're going to be reporting on that evaluation, developing a framework, piloting that framework, so that by the time we get to April, we're able to disseminate the learning about a proposed new intervention that can be cost effective, that we can roll out to all the ICBs. So that's the plan, that's the process. And I just want to say thank you very much. I think that's my time, and we do appreciate your consideration.
Thank you, Ben, and thank you for that presentation. And thanks to Shona, name removed. It's a really hard hitting truth, actually, what people are going through, and it's something that people don't realize. I mean, the one thing I take from that before I open up for questions from anyone is dementia training currently is not fit for purpose in any form or way in care settings and care services. Yes, we'll probably have those that are really great and do, include the Alzheimer's Society, AGK, they'll have John's campaign involved, and they'll have all those aspects, but it's not a widespread thing. And I think hopefully something that will come out of this is a true approach to training in dementia care. I know Anna in the comments has said that she'd learned more about training with different charities prior to taking on a job in a care home, because the care home dementia training was a 1 to 2 hour webinar, very basic, and that was it. And actually that first-hand vicarious learning is much more beneficial and much more important. Does anyone have any questions for Ben after his presentation? So Ben, what do you think the end game is now for this piece of work that you're doing? What's the goal that you want to see achieved within the ICSs and the change in feedback?
So I think whatever the intervention is going to be, and I think this is what we wanted to see over and get a response first before we came up with an intervention. We wanted to see exactly what the problems were, but it has to be something that addresses that uncertainty. The uncertainty that people are left with, that they have an opportunity to come and speak to someone who will be able to help them. And there are such things as dementia navigators. There's a lot of resources available, but it's about finding it at the right time for people as well. Often it's provided to someone just at the point when they get a diagnosis, and their carers say, actually, if we could have that chat 6 months later. But that's not really a way the pathway works. So I think what we want to do is work out an intervention that can be effective and can remove that uncertainty, and that's really what we're hoping to achieve. I mean, I also have the survey of questions we have for various professionals. If I could share that with them as well here today, that would be super helpful for us to be able to get everyone's views.
Yeah, definitely. I mean, send over everything to us and we'll disseminate that to the group. Dave, I'll come to you and then we'll head off with Sarah. So, Dave.
Okay, thank you. I live in Worcestershire, Sarah, so I'm well aware of the problems that we have with diagnosis. We've been way under target for several years now. I just wanted to say that with all this stuff with dementia, it all depends on getting a diagnosis, and it all depends on having the correct diagnosis. Is there anything we can do to ensure that the quality of the service, the diagnosis service, is brought up a bit, please?
Yes, it's interesting. With the scope of this project was to look at people after they received a diagnosis. But actually what we're finding is that when we're speaking to people, is they're so I'm going to use the word traumatized by the process of trying to get the person diagnosed, that actually that has used all their resources, and they are frankly exhausted by the time the person actually comes to diagnosis. So although the diagnosis rates are certainly up from where they were before, it's not an experience that actually helps people to want to engage more with the services or the health services. It actually puts people off from engagement. So yeah, you're right. We need to look at the diagnosis stage as well, and as well as the post-diagnostic stage.
Yeah.
Thank you, Dave, for the question. And Jack, yes, Jock has put in the chat that they live in America and it's the same over there. You know, high turnover of staff, and poor care qualities. And I have done some work with a home care provider in America, and I was shocked to find out that actually home care isn't regulated in every single state. Anybody can set up to become a home care provider in certain states. Some have their own regulators, some don't. So as much as we chastise the CQC existing in the UK, we have something that does sort of regulate our services. So it's not a UK focused issue. It is a worldwide thing that needs attention. Thank you so much, Ben, for that presentation. If anyone wants to connect, can they connect with you afterwards?
Oh yes, please. And I'll share my presentation out. I'll send it over to Jade and I can be disseminated.